Smoothie King just prior to his crash and wouldn't be ready for sedation for several hours after arrival to the ED. So procedural sedation is exceedingly common. Approximately 1 out of every 100 children who visit an ED for care receive sedation for common medical procedures such as fracture reduction. Conservatively, this translates to 25,000 ED sedations in Canada, 60,000 in the UK, and 250,000 in the US each year. Although procedural sedation is regarded as safe, approximately 1% of children experience a serious adverse event. And arguably the most feared and potentially life-threatening adverse event is pulmonary aspiration, which is defined as the inhalation of oropharyngeal or gastric contents into the larynx and lower respiratory tract. Given that aspiration was such a feared potential complication, organizations such as the Joint Commission on Accreditation of Healthcare, or JACO, the American Society of Anesthesiologists, and the American Academy of Pediatrics published pre-procedural fasting guidelines developed using consensus opinion in the early 2000s. These were organized and published with the goal of reducing the occurrence of pulmonary aspiration in sedated patients. These guidelines specified a minimum fasting period of 2 hours for clear liquids, 4 hours for breast milk, 6 hours for infant formula and light meals, and 8 hours for solid foods containing meat or fatty foods. Given that the Joint Commission accredits hospital systems, and this accreditation is tied to federal funding such as Medicare and Medicaid, these guidelines, which again were developed using consensus opinion, became widespread hospital policy throughout the country. However, some clinical experts believe that pre-procedural fasting guidelines, which were originally based around and intended for patients undergoing elective procedures with endotracheal intubation, were not directly applicable to ED procedural sedation. This was because the risk of clinically important pulmonary aspiration was thought to be significantly less as a result of several differences in baseline patient risk, lack of airway manipulation, maintenance of protective reflexes, as well as the type of medications used for sedation. Furthermore, prolonged fasting has been associated with less favorable outcomes in some patients, and it consumes finite human and physical ED resources during periods of extended waiting. So due to these sentiments, less desirable outcomes, as well as the consumption of valuable emergency department resources, there have been numerous studies evaluating the incidence of adverse events in ED sedations, as well as comparing those adverse events in patients who underwent sedation while meeting or not meeting ASA fasting criteria. One of the first studies published after fasting guidelines were put forth by the Joint Commission, the American Academy of Pediatrics, and the American Society of Anesthesiologists in the early 2000s was Agarwal et al. In 2003. They conducted a prospective observational trial looking at 1,014 children undergoing procedural sedation in the ED, of whom 905 had data on fasting status available. More than half the patients, or 509 to be exact, did not meet ASA fasting guidelines. In this study, there was no difference in adverse events between the fasting and non-fasting groups. There was no difference in vomiting between the fasting and non-fasting groups, and there were no cases of aspiration. Roback et al. Sought to confirm Agarwal's findings and published their prospectively gathered data in 2004. They looked at 2,085 procedural sedations for which fasting time was documented in 1,555 cases. They separated patients based upon their NPO status and further divided them up into groups based upon their last PO intake and looked at adverse events. The incidence of adverse events was the same whether fasting was less than 2 hours, 2 to 4 hours, 4 to 6 hours, 6 to 8 hours, or over 8 hours. Additionally, there were no clinically apparent aspiration events among those 2,000 patients. Treston et al. In 2004 published a prospective observational study looking at 257 pediatric patients undergoing ED sedation. There were no aspirations or cases of intra-procedure vomiting during the procedures. There was no statistical relationship between fasting time and vomiting, but children who were fasted more than 3 hours vomited twice as often as the unfasted children. Babel et al. In 2005 published a prospective observational study of 220 children undergoing procedural sedation in the ED. This was with nitrous oxide. Most, or 71% of them, did not meet fasting guidelines. There were no serious adverse events or aspirations. Vomiting occurred 7% of the time, and there were no statistically significant differences in incidence of vomiting based upon fasting status. And again, there were no cases of aspiration. Bell et al. In 2007 published a prospective study of 400 patients, both adult and pediatric, undergoing procedural sedation in the ED with propofol. Most, 71% of patients, did not meet ASA fasting criteria. There was no difference in adverse events between the two groups. Vomiting occurred in 0.4% of non-fasted patients as compared to 0.8% of fasted patients, or one patient in each group. Again, there were no aspirations. McKee et al. Looked at 471 pediatric patients undergoing ED sedation and published their findings in the Journal of Emergency Medicine in 2018. 43% of children studied did not meet ASA fasting guidelines, and there was no difference in adverse events and no incidences of aspiration. So these smaller studies that I've just gone through laid the foundation for a factual evidence-based approach to ED sedation rather than consensus opinion, and also set the stage for larger multi-center studies. Bell et al. Published a prospective multi-center study out of Australia in 2011, in which 11 Australian EDs enrolled consecutive adult and pediatric patients between January 2006 and December 2008. In total, 2,623 patients were enrolled with an average age of 39.2 years of age. Multivariate logistic regression was employed to determine risk factors for sedation-related events. In this study, there was only one aspiration event out of all 2,623 patients that underwent sedation, and that particular patient had been fasting for greater than 24 hours. There was no association found between time of last oral intake and vomiting, which overall occurred 1.6% of the time. No association between time of last oral intake and aspiration or any other adverse event. So this is a figure from the multi-center study I just mentioned showing that fasting status was not correlated with any clinically significant difference in vomiting or any other adverse event. Again, there was only one case of aspiration in a patient which had been fasting for greater than 24 hours. So seeing much of the data being published regarding the safety of foregoing NPO times for sedation, the American Academy of Pediatrics published updated guidelines in 2016. While they didn't forego their 2002 guidelines and deem sedation without fasting safe, they did admit that the aforementioned studies published a low to zero incidence of pulmonary aspiration, that these emergency medicine studies support a less restrictive approach to fasting for urgent and emergent procedures, and ultimately advocated further research in many thousands of patients to better define the relationships between various fasting intervals and sedation complications. So this charge from the American Academy of Pediatrics was answered by several publications in the coming years. The first was the Pediatric Sedation Research Consortium that same year. They prospectively collected data on a huge number of sedations, 139,142 sedations over 4 years at 42 hospitals. Of the 139,142 patients, there were 25,401 patients who did not meet NPO guidelines for sedation. Aspiration occurred in a total of 8 patients who were NPO and 2 patients who were not NPO. These aspirations led to an event rate of 0.8 in 10,000 for fasted patients and 1 in 10,000 for non-fasted patients. Additionally, there was no significant difference in any major complication based upon fasting status. Another study that directly addressed this charge was Batt et al. In 2018. They performed an a priori planned secondary analysis of a large prospective observational study of pediatric sedations at 6 Canadian pediatric EDs in 2018. They evaluated a total of 6,183 sedations, and more than 50% of these patients did not meet the ASA guidelines for fasting. Among these 6,183 sedations, there were absolutely no cases of aspiration, and there was no association between time spent fasting and adverse events or vomiting. Batt and colleagues concluded in their study that there was no association between fasting duration, and any type of adverse event, and stated that these findings do not support delaying sedation to meet established guidelines. As part of the American College of Emergency Physicians clinical policy process, ACEP did a systematic review in which Godman, the chair of ACEP, published with other ACEP members in the Annals of Emergency Medicine in 2014. They evaluated 5 studies that cover thousands of patients and found no evidence that fasting decreased aspiration or other adverse events. They noted that procedural sedation is a distinct entity from scheduled procedures which require either paralysis or intubation, and wrote that the combination of vomiting and loss of airway protective reflexes is an extremely rare occurrence with procedural sedation and analgesia, making aspiration an unlikely event. Their recommendation based on this systematic review was do not delay procedural sedation in adults or pediatrics in the ED based on fasting time. Pre-procedural fasting for any duration has not demonstrated a reduction in the risk of emesis or aspiration when administering procedural sedation and analgesia. The American College of Emergency Physicians took the evidence which I just mentioned, as well as the numerous other studies which we have gone through, and have published an official multidisciplinary consensus practice guideline for unscheduled procedural sedation in 2018. Their goal was to create a clinical practice guideline specific to unscheduled, time-sensitive procedural sedation, which differs in important ways from scheduled elective procedural sedation. In these guidelines, they stated, currently there is no evidence that noncompliance with elective fasting guidelines increases the risk of aspiration or other adverse events. Any concerns regarding aspiration vastly exceed the actual risk. Subsequently, on page 22, in a section titled The Future, they wrote, given the exceptionally low risk of pulmonary aspiration with procedural sedation and absent evidence of an impact from fasting, reform is appropriate for recommendations regarding pre-procedural and oral intake. So we discussed at the beginning of the talk the American Society of Anesthesiologists practice guidelines for sedation and analgesia by non-anesthesiologists published in 2002, which indicated fasting times for procedural sedation. While seeing the abundant data put forth on the safety of procedural sedation, in 2018, the American Society of Anesthesiologists published an updated report entitled it Practice Guidelines for Sedation and Analgesia by Non-Anesthesiologists, an updated report. They made their position very clear in these updated guidelines by stating, do not delay moderate procedural sedation based on fasting time alone in urgent or emergent situations where complete gastric emptying is not possible. These sentiments put forth both by ACEP as well as the American Society of Anesthesiologists were further supported in updated clinical practice guidelines for the use of propofol, published by Miller et al. In 2019 in the Annals of Emergency Medicine. They stated, the literature does not support a significant association between fasting length and incidence of adverse events in adult or pediatric patients. The urgency of the procedure dictates the necessity of providing sedation without delay, regardless of fasting status. Finally, in 2020, the Multidisciplinary International Committee for the Advancement of Procedural Sedation put the final nail in the coffin. Green et al. In 2020 published the committee's conclusions after a truly exhaustive review of the current available literature and presented the first fasting and aspiration prevention recommendations specific to procedural sedation. They wrote, the literature evidence is clear that fasting as currently practiced often substantially exceeds recommended time thresholds and has known adverse consequences. For example, irritability, dehydration, and hypoglycemia. Fasting does not guarantee an empty stomach, and there is no observed association between aspiration and compliance with common fasting guidelines. The probability of clinically important aspiration during procedural sedation is negligible. In the post-1984 literature, there are no published reports of aspiration-associated mortality in children, no reports of death in healthy adults, and just 9 reported deaths in adults of ASA physical status 3 or above. Current concerns about aspiration are out of proportion to the actual risk. This slide shows a figure from the committee's published guidelines, and without going through each point, you will see in the highlighted areas various risk factors and level of risk. At the bottom, you can see in non-elective procedures, such as those urgent or emergent situations encountered in the ED, regardless of risk factors or level of risk, the recommendation is the same. Do not delay based on fasting time. So what kind of an impact can either following fasting guidelines or foregoing fasting guidelines have on an emergency department and its patients? Well, Dr. Derek Kelly of the Campbell Clinic and his colleagues studied this and presented their results with the title Hunger Games at the 2020 annual meeting of the Pediatric Orthopedic Society of North America. Their results were also published in the Journal of Emergency Medicine just a few months ago. He and his colleagues looked at 2,674 patients who presented to a level 1 pediatric ED and required procedural sedation for orthopedic injuries. Patients were categorized into the following groups. 1, those already within ASA fasting guidelines and presentation to the ED. 2, those that had procedural sedation not within the ASA guidelines. And 3, those that had procedural sedation after fasting in the pediatric ED to meet ASA guidelines. Primary outcomes were length of stay, time from admission to start of sedation, length of sedation, time from end of sedation to discharge, as well as adverse events. As you can see in this graphical representation, they noted a significant difference in the length of stay and time from admission to sedation, both approximately 80 minutes longer for each patient and those with procedural sedation after fasting in the ED to meet ASA guidelines. This p-value was less than 0.001%. There was no significant difference among groups in lengths of sedation or time to discharge after sedation. And as seen in all of the prior studies we've gone through, there was absolutely no difference in adverse events and no instances of aspiration. This is a graphical representation from that study showing the number of patients and the type of meal for which they had to wait to meet fasting guidelines, as well as the subsequent amount of time it cost both the patient and the ED. I think we can all agree that at a busy level 1 adult and pediatric trauma center, where beds and resources are at a premium, especially now, that 1,500 hours of waiting for fasting guidelines to be met without evidence to support it is time that could be better spent on valuable patient care. However, I do have the privilege of delivering some good news that there are some exciting changes ahead. Atrium sedation policy has had some recent proposed changes to include removal of NPO guidelines. This actually went to the executive committee for approval last week. It was approved, so look out for changes on the horizon. So back to our cases. NP, our 9-year-old who tripped and fell, sustaining the salter-Harris distal radius fracture. She unfortunately had to hang out in the LCH pediatric ED until 2:30 a.m. until she was ready for sedation. However, she did successfully undergo procedural sedation by the awesome pediatric emergency department team, was reduced and placed into a cast, which can be seen here, and this was her definitive management. CB, our 30-year-old male who sustained a right bimalleolar ankle fracture dislocation, as well as a left subtalar fracture dislocation with an associated medial malleolus fracture, was able to have his right ankle reduced and splinted with pain dose ketamine alone. However, he waited in the ED until his NPO time was up for several more hours to allow enough sedation for his left subtalar fracture dislocation to be reduced. After bilateral lower extremity reduction, he was placed into splints, and that temporized him for 4 days until ultimately he had ORIF of both his right bimalleolar ankle fracture dislocation as well as his left subtalar fracture dislocation with an associated medial malleolus fracture. So in summary, procedural sedation is safe. Serious adverse events are rare. Aspiration risk is negligible, approximately 1 in 10,000, and fasting status is not associated. Concerns of aspiration are out of proportion to the risk, and recent guidelines by ACEP as well as the American Society of Anesthesiologists recommend no delay based on NPO time alone for ED procedures. This policy has recently been approved at Atrium, and there is an expected go-live date of 5/24. I would like to thank Dr. Brian Scannell, Dr. Brian Brighton, Dr. Michael Gibbs, and Dr. Stephen Colucciello for their help and assistance with this talk. I would also like to thank my great support system, my wonderful wife, kids, and as always, my rock star co-residents. I'll take time for questions or comments.
Thank you, Joseph. That's great. A very timely grand rounds with the recent change in the hospital policy. That was my first loaded question: is when are we going to catch up? But obviously, we did. So that's great to see. I mean, having worked in RER for my whole residency, this is going to be a huge change in workflow. So I'm sure that this was greeted with open arms by the emergency room folks as well. Anyone have any specific comments or questions for Joseph?
So Dr. Pat's Mike Gibbs from Emergency Medicine, and Dr. Jolissaint, that's the best talk that I've seen on the topic to date and the most comprehensive. So thank you so much for summarizing, I would say, the entirety of the relevant literature. And I think this just represents an example of how tenacity and trying to arrive at the real answer in medicine is really important. So we've been living with NPO guidelines now for decades, and now to be able to move forward as you've described this morning is going to be extremely beneficial, obviously, first and foremost for our patients. So thank you for a really articulate presentation. And like you and your colleagues, we look forward to the new day that's almost here, where we can do the right thing for our patients while keeping them safe and providing them with outstanding care. Thanks again.
Thanks so much, Dr. Gibbs. Appreciate it.
Excellent. Thanks, Mike, for your comments. Joseph asked you to stop sharing your screen, and I will introduce Dr. Steve Monk. So we have one of our neurosurgery residents talking today.